Our next section is seizures. Seizures can be broken up into partial seizures. They can be broken up into a generalized seizure that is absence. They can be broken up into a generalized seizure that is tonic and clonic and relaxation and contraction, and status epilepticus, which simply is the seizure doesn't stop. As the name might imply, a partial seizure is limited to one part of the body. My arm is twitching rhythmically, my leg is twitching rhythmically, and it doesn't spread to the other part of the body. That's the most important thing. What you might think of as a Jacksonian march, where it starts out with a twitching hand, then a twitching arm, then you lose consciousness and it's the whole body. That is not the partial seizure. The partial seizure means it just doesn't go anywhere in the rest of the body. Now, the partial seizure can either be simple, and this word simple simply means that you stay awake. You have an intact consciousness. You don't pass out. You're awake watching your arm or leg twitch. Or a complex, and the word complex means you lose consciousness and you're not aware of what's going on. One of the main ways you can ask people about this is when you are having your seizure, could you hear people talking? Could you hear them talking? If you can hear them talking, you're not having a complex seizure. Complex seizures do not allow people to hear things. Whether you prefer the more precise term of absence seizure or the more poetic term of petit mal, a little bad, it is a generalized seizure in the sense that consciousness is briefly impaired. It can present with, for instance, students who suddenly look like they're not paying attention in class. You say, why aren't you paying attention? Staring off into space. Well, for a child who has a new onset seizure disorder, this can be something that makes a child have a behavior problem in school, and it's an undiagnosed seizure disorder. And that's because you remain upright. You don't fall to the floor and convulse and clonically contract and relax. You just stay stock still and stare, and then it only lasts for a few minutes. So in fact, people nearby may not even notice it's occurring. It occurs, and this is extremely important, more often in children, and this has always been the case, and that is why for childhood behavioral disorders of certain types, you have to make sure they're not having a simple absence seizure. A generalized seizure is sometimes referred to as a tonic-clonic seizure, and this generalized seizure has varying phases. And those varying phases are muscular rigidity. Everything becomes tight. Like the flaccid paralysis is called atonic without tonicity. Muscular rigidity is called tonic for complete rigidity. And this is followed by jerking movements, and that is what the word clonic means. Clonic would be like flapping, flapping, flapping. Goes on for a few minutes. Or, if it doesn't stop at all, we simply call it status epilepticus.
Now, one of the causes of generalized seizures is hyponatremia or hypernatremia. Either high sodium causes seizures or low sodium causes seizures. Hypoxia causes irritation of the brain. Hypoglycemia, when you starve the brain for any essential nutrient, it becomes upset and irritated and hyperirritable, and it causes a seizure. Any CNS infection, such as meningitis, encephalitis, or an abscess, can serve as a focus of a seizure and start the electrical malfunction. Any CNS anatomic abnormality, such as trauma or stroke or tumor. Now, these causes of seizure disorders are indispensable for you to know because it's not just high sodium, but low sodium. Any irritation of the brain at all can cause a seizure. Now, you'll notice what's absent from here is that potassium disorders do not cause a seizure. Calcium disorders can cause a seizure when the calcium level is low. It causes neural hyperexcitability. It's like Trostek's sign and Trousseau's sign, neural hyperexcitability. Uremia, because the accumulated waste products, such as the elevated creatinine and the nitrogenous waste products that accompany it, cause cerebral irritation. Hepatic failure as well. Withdrawal of certain drugs, particularly alcohol, barbiturate, and benzodiazepines, all can cause seizures. Now, barbiturate and benzodiazepine toxicity won't cause a seizure. Alcohol toxicity will. Alcohol will cause you to have a seizure both at the withdrawal as well as the toxic levels. Cocaine toxicity only, not cocaine withdrawal, but cocaine toxicity will cause seizures, and rarely low magnesium can do it. Seizures of unclear etiology are called epilepsy. If there is a clear cause, it's not epilepsy. By definition, you would only call it epilepsy if you've excluded all of these other features.
When is the answer electroencephalogram? Well, the answer is when all the other tests we just talked about, glucose, oxygen, sodium, urine toxicology, head CT, all of those things are negative, do an electroencephalogram. Well, what for? I mean, what difference does it make? Well, if the CT and MRI is normal, then you say, well, if there's an abnormality on the EEG, you may start seizure medications, or anti-epileptic therapy, as it is more properly called. A person who has a seizure and no clear etiology must have an EEG. Why? Because the EEG has greater sensitivity for certain electrical abnormalities that say, ooh, that pattern is associated with a recurrent seizure. Abnormal EEG should be treated. But there is no point to do an electroencephalogram if you have a clear reason. There's no reason to do an EEG if the sodium or glucose or oxygen is abnormal, or if the calcium is abnormal, or there's an anatomic defect. That's not what the EEG is for. EEG is for seizures of unclear etiology.
Delirium, stupor, and coma are an altered level of consciousness. This is very different from dementia, which is simply memory loss. In dementia, you can say to a person, "Hello, how are you?" and the person can respond, "I'm fine, how are you?" But that's different than delirium or stupor or coma, where people simply cannot pay attention. "Hello, how are you?" It's very different. You're unresponsive to stimuli. You have toxic metabolic and CNS infections that all can cause it. You see, these terms are very hard to distinguish from confusion or difficulty with arousal, obtundation, and when a severe enough one occurs, it's a seizure. For instance, the worst form of delirium or stupor is a seizure. Confusion is to a coma and seizure like angina is to a myocardial infarction. In other words, the worst form of angina is an MI. The worst form of confusion is a coma or seizures.
The only form of seizure treatment that's truly clear in terms of what to use first, what's next, is status epilepticus. That's the only one. If the person comes in with a seizure that just doesn't stop and they're seizing, the best initial therapy is a benzodiazepine. It doesn't matter which one, lorazepam, diazepam, it doesn't matter. And there's no maximum dose. But if the question says they've gotten 2 or 3 injections of it, it won't work. 2 or 3 or 4 injections, 5 or 6 is not going to work after you've tried that benzodiazepine. The person has had a benzodiazepine and they're continuing to seize. What's the next best step? It is a phenytoin or fosphenytoin. And the only difference between phenytoin and fosphenytoin is that phenytoin has toxicity that is associated with hypotension AV block, and fosphenytoin is not. Fosphenytoin doesn't cause AV block. Fosphenytoin has fewer adverse effects. Phenytoin can cause hypotension AV block because phenytoin is a class 1B antiarrhythmic in the same group as lidocaine, and fosphenytoin can be given faster because it has no blood pressure or cardiac effects because it is converted into phenytoin in the body, and therefore you can give it IV as rapidly as you like. If the benzodiazepines did not work and the fosphenytoin did not work, then the next best step in the management of this patient is a barbiturate, phenobarbital. This management hasn't changed in 25 years. The only thing new in the last 25 years is that phenytoin is more routinely given as fosphenytoin. Now, it's not called fosphenytoin because it really is just because you can give it foster, but it does work out that way. It's like a faster version of phenytoin. You gave them a benzodiazepine, it didn't work. You gave them fosphenytoin, it didn't work. You gave them barbiturates, it didn't work. What is the next best step in the management of this patient when those first 3 different classes don't work? You will do neuromuscular blockade, so you can put them under general anesthesia, neuromuscular blockade such as succinylcholine, vecuronium, pancuronium, and then you use these agents to paralyze the patient so you can put them under general anesthesia. with midazolam, pentobarbital, propofol, and then you put them on a ventilator because everyone knows propofol can stop breathing. And the neuromuscular blocking agents, they don't stop the seizure. They don't really stop the electrical activity in the brain. They just stop the external manifestations. The brain is continuing to cook, but their muscles just don't contract. Now, status epilepticus is precisely defined as greater than 30 minutes of seizure. But how we use the term is a seizure that simply doesn't stop spontaneously. So status epilepticus is always considered a medical superemergency. If it doesn't stop with benzodiazepines or fosphenytoin or phenobarb, then that automatically means that this person should be placed in the intensive care unit because this is the person who's going to get general anesthesia, neuromuscular blocking, and major medications such as propofol, midazolam, pentobarbital, thiopental to stop the seizure. We simply don't treat single seizures in the vast majority of cases. Seizure medications, anti-epileptic therapy is indicated only for people who have something special. I take care of patients every week who are admitted to the hospital with a new onset of seizure disorder. And as the receiving hospital for John F. Kennedy Airport, we get people brought in from the airport all the time off the planes all over the world who never had a seizure disorder before. If it is one seizure, you should not start long-term therapy. Except when should you do it? There are a couple of exceptions. One is that the person didn't stop spontaneously. They kept seizing and seizing and seizing and seizing, and they didn't stop until you gave them the medications we just described. Benzodiazepines, fosphenytoin, phenobarbital, one of them. And you don't have to have all of those things. You don't have to use all those meds to be considered status epilepticus. The bottom line is the vast majority of seizures stop spontaneously after a few minutes. If it's 20 minutes later and you have to bring them into the hospital to stop that seizure, that's very serious. You've got to start medications in the long term. In abnormal EEG, well, that is the reason we're doing the EEG. Why do the EEG if it's not going to change management? Why do a test? And you have to know before you order that test what you can do with the results. Abnormal EEG after a first-time seizure means much more likely to recur. It means give anti-epileptic therapy. And the other things are a family history of seizures because there are certain rare familial seizure disorders. Now, another possibility is if you, on the scanning of the head, and you find an uncorrectable cause, such as a brain tumor, it's not going to go away. It's going to cause a seizure again. You'd start long-term therapy for that as well. Now, the treatment for status epilepticus is clear. The medications we use in acute setting for people who just don't stop is clear. Benzo, phenytoin, phenobarb, general anesthesia. But long-term epilepsy therapy is simply not clear. Not clear is my way of telling you you can't be asked. Now, no medication is clearly superior to the other. So if your attendings on rotation said, well, I think it should be phenytoin, or I think it should be levetiracetam, also known as Keppra, or I think it should be valproic acid or carbamazepine. Well, that's simply preference. It's not really based on a true assessment of one being better than the other. And I hope your attendings are honest enough to say to you, when you get a question on step 2, they can't ask you to choose between these because phenytoin, valproic acid, carbamazepine have all nearly equal efficacy. Now, one that is clear is ethosuximide is the best therapy for absence seizures. That has always been true. Unfortunately, absence seizures are relatively quite rare. Gabapentin, topiramate, lamotrigine. We might say that's a weird, it went out of order here. Well, you know why? Because we don't want to emphasize these drugs because they're also RANs. They're the other ones that could be used. They're the other ones that do have some effect, and there's no one that can clearly tell you one is better than the others. You cannot be asked to choose them based solely on efficacy. Now, it is clear that if a single agent doesn't control someone, an alternate can be tried. And if it's still not controlled, a second medication is tried. And if multiple medications don't work, that's when you start thinking about surgery for the seizures. Now, we have mesial temporal lobe cutting can cut the temporal lobe, cut the seizure pathways that go through the brain. Now, these pathways of treatment are not precisely clear. It's not clear. No one can ask you, should you try it for 2 months or 4 months or 6 months, which first drug, which second drug, not clear at all. If we're speaking in generalities here in this section, it's because we have to. There isn't anything clear. It is clear that alcohol withdrawal seizures don't need long-term anti-epileptic drugs. Now, that's really important because your mind, particularly the high-functioning students or the people just simply anxious, are going to obsess over, oh my God, what if they ask me, to choose between them? And your mind goes into, I'm going to be asked some unanswerable question. I'm sorry, that's just not the case. Instead of asking you between different drugs that all have equal efficacy, they'll ask you, hi, who should be treated with a first-time seizure? Oh, abnormal EEG, a focus you can't correct, family history, status epilepticus. That's clear. They should be treated with the first one. Oh, alcohol withdrawal seizures. What's clear? They should not be treated. It is extremely difficult to know how long you have to wait before you can stop seizure medications, anti-epileptic medications. It's extremely difficult. And why this is so important is you tell people you can't drive. You tell people you could fall into subway tracks. You tell people you can fall off of platforms and fall off a dock. And so it's extremely anxiety provoking to not know when you can stop your medications. So I have for you a bottom line basic answer. The approximation is you have to wait until 2 years of seizure free for 2 years. And then you may be asked to do a sleep deprivation EEG as which of the following is the most sensitive method of detecting a possible recurrence of seizures? Which of the following is the most accurate test to determine whether a person has a high risk of seizures post stopping the meds? Sleep deprivation EEG. Well, what it does, it's not only the best way to detect the possibility of recurrence, it elicits abnormal activity with more sensitivity. And although it's not a 100% test, it's kind of like a stress test for your brain, stress thallium for the brain. Hey, the EKG didn't show anything. Let's put you on a treadmill. Let's put you on a stress thallium. We want more sensitivity. And that's what a sleep deprivation EEG is. It is a more sensitive EEG. A 38-year-old man is evaluated for seizures, and he achieves partial control with a second medication. He drives to work daily. What are you going to tell a guy about his driving, huh? The answer is, take a minute to read. Well, you can't confiscate his license. That's not your job. You can't do that. You can tell him, hey, listen, you got to find a different way of transporting yourself to work. I know that seems rather wimpy and namby-pamby, but that's the rules. You see, once again, this is an area where students will often get very upset. They'll think, well, it doesn't seem right. You should be able to confiscate his license. But you can't. The rules vary from state to state, and you're not the Department of Motor Vehicles. You're a doctor. You can't just say that you can't prevent them from driving. You can't prevent them from driving. You don't have the ability to tell a guy, hi, I'm taking your car keys. And you can't say, listen, I'm going to let you drive as long as your seizure history is noted on your license, as if noting it is on your license. Okay, well, I won't seize now. It's on my license. And you can't let him leave you can't prevent him from leaving the office. You can't incarcerate people because of driving. It's not tuberculosis. If it's tuberculosis, you can incarcerate him, but you can't for driving. And the issue about being accompanied does not stop you from having a seizure. In other words, if we can prevent seizures by accompanying you, or somehow or another that means that if you have a sudden seizure that somebody can grab the wheel before you run over someone, that's just not accurate. I'm afraid you're stuck with this answer. All you can do is tell the person he's got to find different means of getting to work, and that's it.